Am I audible? Enoch?
Yes.
Thank you. Thank you very much to everyone who has joined us. We like keeping these sessions short. And today we have the honor of having Dr. Winnie Mwebia. Winnie Mwebia is an obstetrician gynecologist from the University of Nairobi and currently based at Ishihara Sub-County Hospital in Embu. She's passionate about maternal health and safe motherhood. And she is the coordinator of this program. She has had several research publications in maternal health. And just before Winnie comes in, we want to tell you that these are CPD accredited points. We will be generating CPD points from different areas of the people who do CPD for you. And we have a mixed cohort of doctors, of nurses, of clinical officers. And with that, we want to welcome Dr. Winnie Mwebia to take us through the first part of our 12-part series on overview of maternal health. Dr.
Okay, thank you so much, Dr. Kigondo and Enoch, for the kind welcome. As you heard, my name is Winnie Mwebia. I'm glad to have you all this evening to this first series of this particular cohort of the telemonitoring series. We aim to continuously develop our professional capabilities as maternity health providers, as well as teamwork within our business facility. Not speaking mute. Thank you. So I hope that the series will be of value to us and help us improve care in our various health facilities. So the session for today, we are having an overview of maternal health. Just give me a minute. Yes, so overview of maternal health. So this is the first lecture that will form the basis for all the subsequent series that we'll have. So the outline of this will have an introduction. So we look at the significance of maternal health. We define various terms. We look at the spectrum of maternal morbidity and mortality, the causes of maternal morbidity and mortality, as well as the data, and reduction of preventable maternal deaths and morbidity as well. We're also going to look at the 3 delay model in maternal health and how we can optimize obstetric care in the various facilities, and summarize with the case presentation. So in introduction, maternal health, as we all know, it's the health of a mother during pregnancy, delivery, and postpartum period. And we know that maternal complications and death can occur in any of these phases and without warning. So each pregnancy and delivery is unique and should be treated. So in fact, all pregnancies and deliveries should be considered as potentially high-risk deliveries and pregnancies. So care in each of these pregnancies should be optimized so as to ensure that we have full potential of the well-being of both the mother as well as the baby. So maternal ill health or death has profound effects on the economy, the health, and the social well-being of both the children, the families, and societies in general. So if we look at the consequences of maternal morbidity and mortality, they are huge and they are fast spreading. If you look at the health consequences by premature loss of life, women who are in the reproductive age group tend to be young women, so that would be termed as premature loss of life. And the ensuing disability, even if this mother lives but with a complication. We've seen women who have had to undergo chronic dialysis or even they've had renal failure due to arising from complications of pregnancy. And then the ensuing poor health of dependents, especially children, or even mortality of surviving children. So it is known that once a mother dies, the surviving child has a lower survival prospects. And then if you look at economically, also the medical cost of treatment of all these complications, they send families into bankruptcy, the reduced or the loss of income from the mother who has died or incapacitated by the complications. And then you have to reallocate roles in the family if the mother is incapacitated or not there. Psychological, there's a lot of grief, loss of key family giver, as we know that mothers are the key family caregivers in the family. So if you lose a mother, you rearrange all that, and most likely they are going to need a replacement, like a stepmother, and you know it's never quite the same. The surviving children also not likely to have the optimal education. So that's why we need to preserve the health of mothers during pregnancy and childbirth. So looking at various definitions, so maternal morbidity, it's the unintended outcome of the process of pregnancy, labor, and delivery that will result in significant short or long-term consequences to a woman's health. So, and then on the other hand, maternal death is the death of a woman during pregnancy, childbirth, or within 42 days of pregnancy termination. And this is from any cause related to or worsened by pregnancy or its management. And this excludes accidental or incidental causes. So if a mother, let's say, gets a road traffic accident, head injury, and dies, that is not termed as a maternal death because it's accidental. So, and this is irrespective of the duration and site of the pregnancy. And this is the WHO definition. So maternal mortality ratio is the number of maternal deaths during a specific given period of time per 100,000 live births during the same period. And this is the main index that we use to measure maternal mortality. So we can have either direct or indirect maternal deaths, and the direct ones are those that result from obstetric complications or those complications arising from pregnancy, delivery, and postpartum period up to 42 days, and also those that result from interventions or omissions of treatment resulting from these complications. For instance, if you have a mother dying from, let's say, overdose of magnesium sulfate, that is a death from intervention of a direct obstetric complication. So it would be a direct obstetric death. The indirect ones are those that arise from a previously existing disease or one that developed during the pregnancy, but not a direct obstetric complication. So for instance, anemia would be the commonest, cardiac disease, malaria, diabetes, and then for HIV, they are usually classified as either HIV-related maternal deaths, and this would be a death due to a complication or a HIV complication that was actually worsened by the pregnancy. So for instance, anemia that may have been related to HIV, but worsened by pregnancy would be termed as a HIV-related maternal death. But for an incidental HIV death is any other complication that would have resulted to death even without the presence of pregnancy. Let's say a woman who had cryptococcal meningitis and they died while pregnant. So that would be incidental. Then late maternal deaths, those that occur after 42 days to up to a year postpartum. Then we're not just talking about deaths, we are also talking about morbidities. And one of the severest morbidity, maternal morbidity, termed as maternal near miss. And this is again defined by World Health Organization as a woman who nearly died, but survived a complication that occurred during pregnancy, childbirth, or within 42 days of pregnancy termination. And the survival is either due to pure luck or pure chance, or due to the good care that they receive in the health facilities. So one of the indices that is used to measure maternal near misses is the maternal near miss ratio, which is the number of maternal near miss cases per 1,000 live births. So you can view maternal morbidity as a spectrum that ranges from mild complications all the way to the severe life-threatening complications and death. And at the extreme end of this spectrum, you have the severe maternal outcomes, which is made up of the near misses and deaths. And the difference between the two is just the final outcome. So this is further to illustrate the same. If you look at this pyramid, at the very bottom, you have the pregnant population without complications. And this tends to be the biggest population. Most pregnant women that you'll come across will not have any complication. Then there are those few who will develop mild pregnancy complications. And then out of the ones who develop mild pregnancy complications, there are those that will be severe complications. And the World Health Organization has defined 5 such severe pregnancy complications, and that's severe postpartum hemorrhage, severe preeclampsia, eclampsia, ruptured uterus, sepsis, and severe complications of abortions. So once a mother develops organ dysfunction from these severe complications, then they're termed as a severe maternal outcome. And these mothers will either survive if they get good care or by chance and they become near misses, or die. So the goal of obstetric care is to keep as many women as possible at the bottom of the pyramid. And I'll give an example to illustrate that. During antenatal care, mothers should have urinalysis or screening for asymptomatic bacteria. So if we do that screening and probably find that they have this asymptomatic bacteria and treat it, then we maintain those mothers at the bottom. Supposing that either the screening was not done or inadequate treatment was given, then this asymptomatic bacteria may progress into a UTI, maybe a cystitis or pyelonephritis. And that would be termed as a mild pregnancy complication. And these again can be treated. But supposing that it's not treated adequately or it's not even diagnosed in the first place, then they may go on and develop urosepsis. So that puts them in the PTLC category. If this urosepsis again is not treated in good time, it can go on to cause acute kidney injury. So once you have organ dysfunction, that mother is at the top of the pyramid. And what lies between her and death is the care that she gets at the facility. So she can either survive with good antibiotics, dialysis, and become a near miss, or go ahead and die. So the point is, we want to keep as many women as possible at the very bottom of the pyramid. So what are the causes of maternal deaths? So we've talked about the direct and indirect. So direct causes contribute up to 74%. Again, this is data from World Health Organization. And among these, hemorrhage, hypertension, and sepsis contribute to up to 50%. And if you look at the causes of maternal near misses and maternal deaths, they are very similar. The most common cause of either deaths or near misses is obstetric hemorrhage. And this is the case globally as well as locally in Kenya, followed by hypertensive disease and sepsis or pregnancy-related infections. So if we look at the numbers globally, about 800 women die daily of pregnancy-related complications. And virtually most of these women, 94%, are in the low middle income countries. So if we are to put this into perspective, 800, it's almost the size of an Airbus. That's the largest airplane. So you can imagine if we were to crash an Airbus daily, that's a global disaster. That's what maternal deaths are. So the global lifetime risk of a mother of maternal deaths is 1:190, and you can see the wide disparity between the developed. So the risk is much lower in the developed world, that is 1:5,400, versus in the developing world, which is about 1:45. So in Kenya, this risk is about 1:76. And maternal mortality has been a historical issue. There used to be a folklore back in the day in Tanzania, where a woman who's going to deliver would tell the family that she's going to the sea to fetch a new baby, but the journey is long and dangerous and may not return. But now in the 21st century, this is something that should change. So according to, again, data, WHO, UNICEF, for every one woman who dies, there are 20 or 30 others who suffer disability, either short-term or long-term. If you look at this map again, you can see the areas which are worst affected by maternal mortalities. That's the sub-Saharan Africa, the areas in red, orange, and yellow. Then if you go to the north of Africa and south, the deaths are much lower. You go to Europe, Australia, America, and most of South America, the maternal mortality rate is quite low. So there's a lot of regional disparity. Okay, so we've talked about the data. Just to discuss the Sustainable Development Goals on maternal health. So this is a Sustainable Development Goals is a global developmental agenda basically. And the third one is on health, to ensure healthy lives and promote well-being at all ages. So the first target of the third agenda is that by 2030, globally, the maternal mortality ratio should reduce to less than 70 per 100,000 live births. And you've seen the ratio for Kenya is around 362. You can see where we are. So for every country, by 2030, we should be able to reduce maternal mortality ratio by at least 2/3, and that is from the 2010 baseline. So our baseline in 2010, according to the 2009 KDHS, we were at around 488 per 100,000 live births. So if we are to cut that by 2/3, it means by 2030, we should be at least 160 and less. The other supplementary is that by 2030, no country should have a maternal mortality ratio of higher than 140. That is twice the global target. So you can see that the target for each country is dependent on their baseline levels. And even for those countries with very low, much lower than global, the global average, they should contribute towards equity in achieving the global agenda. And mostly that's through financial support to the less developed countries. So how can we reduce preventable maternal deaths? It is a fact that we've seen that up to 75% of deaths are preventable. And if you look at the most causes of maternal deaths, if it is preeclampsia, if it's postpartum hemorrhage, sepsis, we have known interventions for all of them. So what is it that causes these many maternal deaths? So we know that they can be prevented through timely attendance by skilled health personnel and in a supportive environment. And there's an emphasis on timely because when we are dealing with maternal complications, time is of essence. For instance, when you're dealing with hemorrhage, depending on the severity, you have about between 2 hours and maximum of about 5.5 hours to save the life of this mother. If it's sepsis, it's a range of between 3 days to about 6 days. So, and the earlier the treatment is given, the better. So that's why we're emphasizing on timeliness, so prompt access to quality obstetric services. And the supportive environment that we are talking about, we need a well-trained, motivated, and adequate staff to handle these patients, working in well-equipped facilities, and these are facilities with the EMONC functions. And just to refresh on these EMONC functions, we have the 7 basic functions. That is availability of intravenous antibiotics, availability of uterotonics for active management of that stage of labor, and prevention and management of PPH as well. Neonatal resuscitation should be available. IV anticonvulsants for preeclampsia and eclampsia, manual removal of placenta, manual removal of retained products of conception, and the 7th one is assisted vaginal delivery using either forceps or vacuum. I know most of our facilities, maybe we can take a poll later. How many of us have the capacity to do assisted vaginal delivery? Then for the comprehensive functions, you add 24-hour availability of cesarean section and blood transfusion. And on top of this, we should have supportive health systems and policies. This is like the umbrella of all this, because without the systems and policies, then even the HR and the equipping of facilities will just crumble. So some of the drivers of success in reducing maternal mortality, so they range from making improvements at the provider level and at the health system level, and now the social interventions to reduce various barriers. So yeah, so we've said that the major causes of maternal deaths are few and they have known interventions. And we've said that up to 3/4 are preventable. So timely access is critical. So the goal of obstetric care is to prevent occurrence of severe maternal outcomes and the subsequent disability and the negative impact of loss of life. So there is the 3-delay model, which is a useful tool to identify the points at which delays can occur in the management of these obstetric complications and to design effective solutions to this delay. And this is a model that was described by Thaddeus and Mine in the year 1990. So these are the 3 deadly delays. And the first delay is the delay in seeking care. And this can be influenced by either a delay in recognition of danger signs, as well as a delay in decision to seek care. This could be due to financial difficulties. They don't have money to pay hospital bills, lack of knowledge that this is a complication that should be looked at, traditional beliefs and cultural norms that they say, let's say vomiting in pregnancy is normal, then they don't recognize early when it's becoming too much. By the time a woman is coming, they're already in acute kidney injury, such things. Also concerns about accessibility. If they know that either way they're not going to make it to the hospital, then they may not even decide to go to the hospital in the first place. Then there are communities which have decision makers, either a husband or the mother-in-law. So if the decision maker is not available, then they may not seek help early. So the aspect of women empowerment. If they have previously had bad experiences in health facilities, then they may decide not even to go there to seek help in the first place. Then the second delay is the delay in reaching care. So this has to do with the actual movement from home to the facility. So this can be influenced by things like lack of transport, the transportation costs, distance, the physical distance or the physical barriers on the way to health facilities. Then the third delay, which is the delay that we're going to focus on, is the actual delay in receiving care. So this is the delay in obtaining adequate and appropriate healthcare within the healthcare system. And this can be due to either lack of equipment and supplies, lack of trained staff, poor staff attitude, and also, as we are going to see, our referral processes do delay patients a lot. There's a fourth delay that is emerging, and this is the delay in taking responsibility for maternal deaths. So if we keep burying our heads in the sand, we may not be able to be in a position to devise good, appropriate interventions for these delays. So if we look at that delay in our local context, there was a confidential inquiry into maternal deaths, the first one that was conducted in the year 2017, and they looked at maternal mortalities for the year 2014. So what was identified was substandard care contributed to up to 90% of maternal deaths. So we can say 9 out of 10 of women who died could have been, their lives could have been saved. So delay in starting treatment was about 33%. Inadequate clinical skills of the staff was about 28%. Inadequate monitoring about 27%, and these were the most frequently identified health workforce related factors. So if we look at the main killer of mothers' obstetric hemorrhage, again, 91% of those women who died from hemorrhage, again, received suboptimal care. Okay, so it was noted that improving care of in 88% of these women who died would have resulted to better outcome. And then half of all the women who died had been referred from other facilities, either level 4 to a level 5, level 5 to a level 6. So you can see how referrals are contributing to these data. Then again, a significant number, almost 3/4 of all these mothers who died, the deaths occurred outside the working hours, that's after 5 p.m. and before 8 a.m. and over the weekends and public holidays. So that also puts emphasis on appropriate coverage during these hours. So there was also another study that was conducted on maternal near misses in, I think it was 30 counties in the country. This is a 2020 study. And they found that the severe maternal outcomes, which we said is a combination of the near misses and maternal deaths, the ones which occurred before hospital admission accounted to 64%. So that's factor of first and second delay, although I'm going to explain that further. So severe maternal outcomes which occurred during the hospital stay were 36%. So up to the 64%, referrals accounted for 58%. So you can see again the emphasis on referrals. So this implies that about 2/3 of all the severe maternal outcomes can be attributable to the third delay. That's a delay within the health system. And that's what we hope to address through this series. And some of the recommendations that were given, I'll just highlight one, that maternity care providers should have regular, at least 2 yearly, and mandatory updates in emergency obstetric and newborn care, that's including triage and referral. And antenatal care and postnatal care was also emphasized. So this actually forms the basis as to why we are holding, as the Kenya Obstetrical and Gynaecological Society is holding this series, so that we can keep ourselves updated and we can keep reminding ourselves of the various management procedures for our obstetric patients. So to summarize this very short presentation, We've said that maternal health is a key national and global agenda, and our maternal morbidity and mortality, both globally and nationally, remains unacceptably high despite the efforts that have been put in place for reduction. And 3 out of 4 maternal deaths are preventable. And when you're looking at maternal health, we're also considering maternal morbidity, because it's not just about life and death, it's also about the quality of life. We've seen the major causes of maternal deaths and maternal morbidity, and the similarity between the two, and the 3 delays which contribute to these bad outcomes. And we've seen that reducing these delays will go a long way in improving the quality of obstetric care. So hopefully this series will impact on the 3rd delay through awareness creation, as well as fostering teamwork and promotion of evidence-based practices. So I'm going to share with us a case presentation, and then I'm going to open the forum for a discussion. So this is the case of EM, EM was a 27-year-old para 0 + 1 gravida 2 who presented with to the facility at 34 weeks and 3 days with a pervaginal bleeding that had been there for 3 hours. Initially, the bleeding was light and painless, but at the time of presentation, it was heavy and with clots associated with low abdominal pains, mild dizziness, and generalized fatigue. She had no history of trauma. She had not perceived any fetal movements after the onset of bleeding. So the antenatal history, she had attended a clinic twice at a peripheral health center. The first visit was made at 22 weeks, where antenatal profile was done. Hemoglobin was 11.3, blood group B positive. The others were unremarkable. An obstetric ultrasound was requested, and the first tetanus dose and IFAS given. At second visit, which was 4 weeks later, second tetanus dose and IFAS was continued, and an ultrasound that was done had revealed a single live intrauterine pregnancy, fetus rather, in cephalic presentation with placenta previa grade 2. And she was referred to the nearest level 4 hospital for gyne review. The previous pregnancy had ended as a complete miscarriage, spontaneous at 6 weeks of gestation the previous year. She had nothing significant in her past medical history. On examination, she had slight pallor, blood pressure was 170, pulse rate of 105, temperature was 36.7. So on abdominal examination, funnel height was at 36 weeks, longitudinal cephalic presentation, and fetal heart tones were absent. She had moderate contractions palpated with some tenderness on the lower abdomen. So on speculum examination, there was moderate bleeding from the introitus, the cervix was closed, and there was moderate bleeding from the cervical os. So the impression was antepartum hemorrhage, secondary to placenta previa, and possible abruptio placenta, and query intrauterine fetal death at 32 weeks. So the plan was to start an intravenous infusion, IV line. GXM was taken, normal saline drip was initiated, and an urgent obstetric ultrasound scan requested, which confirmed an intrauterine fetal death at 35 weeks of gestation with the placenta previa grade 2 posterior. Emergency hysterotomy was done, and all this was done within an hour of admission. And the findings intraoperatively, there was minimal hemoperitoneum, and there was signs of impending rupture on the left lower segment, and the uterus was dark, what we call Covole uterus, that was suggestive of bleeding into the myometrium. And then there was a rupture placenta, and a fresh stillbirth was extracted, about 2,400 grams. Post-surgery, the uterus was atonic and managed using tranexamic acid, misoprostol, oxytocin, and finally a Billings suture was placed. Estimated blood loss was about 900 ml, and the patient was transfused 1 pint of blood. Post-operative recovery, what was significant, she had postpartum depression, otherwise uneventful, and the patient was discharged home on day 2 after counseling. And it was day 2 because she actually requested to go home. She could not stand seeing other mothers with their babies in the ward. So our discussion points around this case, and I would like to open the floor for any contributions. So how would you describe the patient's outcome? Would you call this a good outcome or a bad outcome? The floor is open. Any volunteers?
I think we had a raised hand. I don't know what happened.
Anyone willing to give their contribution? You can just unmute. Yeah, I'm seeing 2 raised hands. And okay, you're able to tell.
1 second. We have Mary Muyaki. Please unmute, or I can unmute you. Go ahead.
Yes, Mary. What do you think? Do you think this was a good outcome or a bad outcome?
Hi, everyone.
Hello.
Hi, everyone.
Yes, please go on.
Hi.
It's a good outcome because we're the mother being saved.
Because?
We're the mother being saved.
Okay, so that was Ryle. Ryle thinks that that was a good outcome because the mother's life was saved. Anyone with a different opinion?
We have Kezia, who has a different one. They're saying a bad outcome because the baby was lost. The diagnosis for placenta previa was made in good time. If the mother was put on bed rest and close monitoring, the outcome would have been better.
Okay, so thank you for that. Depending on how you look at it, you can say it was a good outcome because the mother lived, but also would have wished to see the mother carry home her baby. So it was not an optimal outcome. The best outcome would have been if both the baby and the mother lived and with no complications. But in the broad sense of things, at least the mother went home. But we want all mothers to walk home with their babies and happy. So I think we've discussed the reasons. Everyone has supported their answer. So what factors do you think contributed to the outcome? Now, I would, let's say that this outcome was not was not the best, it was a bad outcome. So what factors do you think contributed, both patient factors, health system factors, or any other factor that you can think about? Anyone? Yes, Lydia? Okay, from the chat, I see someone said that delayed diagnosis led to complications. Then Michelle says that the facility she went to for antenatal visits should have sent her to high-risk GPC as soon as the placenta was diagnosed. Okay, thank you for your contribution. We can look at the patient factors and the health system factors. So for the patient factors, first thing you note when she started the antenatal clinics at 22 weeks, but granted, it was good enough time to make a diagnosis of the low-lying placenta. It was at for hospital, but it's the kind of referrals that you clear to tell the patient, go. I think in an ideal health system, we should actually link such patients directly to the next health system. As you tell the mother to go to this other facility, at least make a point, but I'm not faulting the health workers. This is a systemic issue that we should have systems for such. Make linkage with the next facility, have a date and a time for this mother to attend clinic and let her understand the urgency of the matter. Because actually, as someone has noted, this mother lost a 2.4 kilogram baby, and this is a baby who could have easily been saved. So again, we've talked about whether it was avoidable or unavoidable. Yes, this was avoidable. The situation was avoidable. The mother would have carried home her baby if she had presented earlier, even at the onset of bleeding. You see, she came in 3 hours after the bleeding started. Although the 3 hours, she did not just sit at home, it was the actual time that it took her from her home to get to the facility. Again, in good health systems where patients are able to call even emergency transport, like an ambulance, to get her to the facility in good time, then would have had a different outcome. So what are the potential areas of improvement, if any? I'll open the floor for that. Any takers? Where can we improve? Where could we have improved the care for this mother and subsequently? Yeah, Beatrice on the chat and Martin talk about the referral system. Anthony also talks about referral system, early diagnosis and management of potential and actual risks. Yes, Grace talks about antenatal health education on danger signs. Again, yes, I agree with you, that is very key. And also the kind of counseling that she received at the referring facility. We don't know what kind of discussion ensued, but if this mother understood the gravity of this matter, I'm sure she would have sought help much earlier. So I see Wanjiro's talking about referral, Mercy Health talk on danger signs. So we all seem to be in agreement. Winnie talks about women empowerment in terms of adequate and health education. Also, that is very key. So we are all on the same page that we need stronger referral systems, and we need also to improve on our patient engagement in terms of health education. So I hope this forms a good basis for this series of webinars, and thank you all for participating. I'll open the floor once again to any questions from participants, and I'm seeing we also have colleagues in attendance. Anyone with any comment or question?
We have a raised hand from Doris. Doris, you can unmute.
Hello. I just wanted to respond on the care that maybe with time you should have some policies whereby you can have every expectant mother be done an ultrasound as a routine in the all healthcare facilities.
Okay. Yes, thank you, Doris. That's very key, and it's actually in the WHO recommendations, and even in our national guidelines that are about to be released. I think it's one of the recommendations that's coming up, and most of our facilities actually have picked this up. So thank you for that, Doris. Very valid. Any other comment, question? Okay, so that's it for this evening. I'll hand over the meeting to Dr. Kigondu.
Yeah, thank you very much, Dr. Winnie. We like to make these presentations short and sweet so that people can concentrate and really enough knowledge. I think with that, we will break for now. We will be back on Wednesday. Again, 7:30 to 8:30, and this time will be on labor and delivery. That is by Dr. Kigondu. Oh, sorry. Yeah, that's me. So we thank everyone for their attendance, and I think this has been a really from Equalize. I can see Lakshmi is back, and Njoki Washir, very much for your facilitation, and we hope to continue working with all of you. As I said, these presentations will be present in the Kogs YouTube page. You can play them over and over again, and we would like your feedback as we go on through the program. Spread the word about the programs, and we will see you on Wednesday. Thank you very much. And class dismissed. Class dismissed.
Okay, thank you. Good night.
Good night. Thank you. Thank you.
Bye.